Right, I will read the chat as well because there's quite a lot of anatomy and physiology. I've just got some notes because my anatomy and physiology. So we are talking today about sepsis, and Amanda has kindly joined us today just because just to say, well, where her team might come in as well to help you if you're concerned about managing sepsis in the community and where it might be. So you can see from this, there's an estimated, there's a lot, 240,000 cases of sepsis each year in the UK, and out of those, there's about 48,000 deaths. So the death rate is about 20% of people with sepsis will die, but it's higher with older people, up to about 30%. And most of them are in the community. And that's why we thought it was important to do this session today. About 70% of the diagnosed sepsis in this country originate from the community. So that's community nurses, primary care, PCNs. And you can see that adults that are 65 years or older are 13 times more likely to be hospitalised with sepsis than adults younger than that. And of 63% of older adults that are admitted to ICU are in ICU because of sepsis. That's more people will die of this than bowel, breast or prostate cancer combined. And the aims of the session today really are to have a look at what sepsis is. We're going to touch on the pathophysiology, which means the abnormal things that happen to your body with it. But I won't go into too much detail, but the slides are here for those of you that are interested in more like how it works, what happens, what classifications are. But we're going to look at the risk factors and common causes and signs and symptoms and how we might manage it. Is there anything that anyone else wants me to cover that I haven't mentioned? Okay, well, you can just chip in if you want, or put something in the chat if you're feeling a bit shy. This is just most of the information I'm getting today is from the Sepsis Trust, who are the ones that have they used to do this called the Sepsis 6, but they've changed it a little bit recently. You might remember when you were doing your ILS and whatnot, we'd say 3 in and 3 out, and it has changed very slightly to reflect more the nuances of this, really. And there's just some stories on here and some awareness raising, but with the proviso, which I'm going to talk to you now, that about older people can present in quite different ways, as I know that you all know this because you're working with older people every day. So we're just reiterating it, really. And we sort of call sepsis as a life-threatening organ dysfunction due to a sort of dysregulated host response, which means it's our abnormal immune response to the whatever is causing this infection, which is what causes sepsis. And septic shock is a subsection of this, where there's a profound circulatory, cellular and metabolic abnormalities, which is what happens when people die, really. It's because of this.
When you're waiting.
It's really hard to define sepsis easily. And if it was easy to diagnose, we wouldn't have 48,000 people dying of it nationally in this country. So it's not that people are not aware of sepsis or not thinking about it. It's that sometimes it can be very difficult to define and diagnose, and the definition of it has changed over time as well. We don't talk about bad infections anymore, really, but about what our body's response to the infection is. And this is what we get for any sort of infection. This is what will happen. You'll get a sort of non-specific inflammatory response. So you get your vasodilation, which you get blood flow that goes to the site so that you're getting your antibodies and white blood cells that will fight the infection. You also get your vessels become permeable, which are a bit leaky, so that antibodies and cells can exit the bloodstream and enter into the infected tissue. This is why it happens. And then once a infection is controlled by your sort of soldier cells, the tissue starts to repair itself. And that's our body's normal response to an infection, which again, I know you know, because you're all mostly people here are nurses or work in healthcare. Any questions? Nothing too cellular, please, Amanda. Okay, but when you've got the sort of sepsis, we're talking about the pathophysiology, so the abnormal physiology becomes that will lead us to multi-organ failure. So you get your normal immune response with your vasodilation. You get your increased vascular permeability. You get increased cardiac output. And what will happen with this is your cells, your fluids start to leak out into your extracellular space, and that puts pressure on your organs. So you start to develop multi-organ failure. And you get this thing called disseminated intravascular coagulation, which is where you'll get the rash, the non-blanching rash that people see. Really, it's where your capillaries have broken down and you're bleeding into your skin. And that's why it doesn't blanch when you put a glass over it. So an inflammatory response is where tissues are injured by either the bacteria or trauma or toxins, and it can go into overdrive. So when it goes into this overdrive, you get really widespread inflammation, which will decrease the blood pressure as well, which that also means that you get a decreased blood supply to your organs, which is the other reason you get multi-organ failure. And this is why we need to try and treat it here before we reach this stage. And sepsis, just to give you a sort of little glimmer of hope, is very treatable. Has anyone got any more questions about this? I'm not sure how much detail to go into. Do you want more detail?
No.
Fair enough.
No.
So the problems are, basically, what I want your take-home message is a abnormal and advanced response from our immune system, which causes these problems. And here, if you click on this, you can get a link just to the inflammatory response video. And this is the results of inflammation as well, where it's abnormal. So with your vasodilation, you get a sort of increase in blood flow to the affected area, which we said. This brings your white blood cells, fibrins and platelets to where they're needed. And this response is achieved through that, which the blood vessels enlarge so that the good stuff can get through. And that's why you'll get redness and warmth in the affected areas. And that's why, crucially, patients with sepsis, although they are going into shock, will sometimes still have warm peripheries. So just because someone's got warm hands or feet does not mean it's not sepsis. Okay? And you get your leaky vessels. So remember, this is partly in a normal response, but in sepsis, it becomes like exaggerated. So it's essential because the pathogens are not restricted to the inside of the blood vessels and the good stuff can get into the tissues. And this is what will cause swelling as well. But with capillary leakage, patients can appear edematous. They can sometimes have a runny nose and they can have diarrhea and vomiting. And people have been misdiagnosed in A&Es because they presented with diarrhea and vomiting, which was their symptoms for sepsis. Okay, so if you have someone with a runny nose or dizziness, diarrhea or vomiting, these are all signs of sepsis as well. Okay. And if you get an acute inflammation, you get this whole load of sort of cytotoxins, they're called, okay? And so in sepsis, this delicate balance between the pro-inflammatory and anti-inflammatory molecules, which should regulate, are sort of out of balance, and the inflammatory response is not controlled, so it becomes sort of damaging to the body. And this is what it will look like, which I won't go into too much, but this is this sort of cellular response you're looking at for those of you that are interested in it. Okay. So what's happening really, you get a stimulated coagulation response and you get an inhibited anticoagulation response. So people are going to bleed as well. They're at really high risk of bleeding, and it's really going to drop their blood pressure as well. Happy with that?
Yeah.
Not happy, but okay, these are sort of the terms we use. I think you've heard of these terms, haven't you? So we don't use the term severe sepsis anymore. What you might hear is SARS, so systemic inflammatory response syndrome, and that's more based on people's observations. We don't use septicemia as well. So semia is always something which means in the blood, but we don't use that term because it's a bit misleading. So this is what systemic inflammatory response syndrome looks like. And it's based on observations. So people can be very hot or very cold. So not everybody will develop a temperature with sepsis either, especially not your older people who may not be able to. The temperature that we develop is our body's way of trying to kill the whatever the pathogen is that's causing the infection, so the virus or bacteria. So older people might not be able to mount that response, or younger people that are being overwhelmed by their sepsis. So don't just because someone hasn't got a temperature, you can't rule out sepsis. A respiratory rate of above 20, a heart rate of above 98, if your blood glucose is above 7.7 or they've got newly diagnosed confusion, okay? If you've got 2 of these symptoms or more, we need to suspect SARS or the systemic inflammatory response syndrome, okay? You get hyperglycemia because you get a bigger release of glucose because of the stress response during sepsis. But if you've already got your diabetics on on insulin, you may not see that. So that's something else to bear in mind, okay? And we should be very good at spotting these early warning signs because these are basic observations and they'll be the first sign we've got that someone's becoming unwell. Any questions or anything you want to add, anyone? Or Amanda? With older people, just a bit of caution. Okay, they're obviously at increased risk of getting an infection because the immune system doesn't work as well as younger people, and they've got all the other age-related changes in their bodies. So that's why they're at increased risk of sepsis. Some of these references are a bit old, but I think there's a general. Lots of the research doesn't disseminate older people from younger people, so that is why some of it's a bit old. So a bit older people for us will often present with atypical, really non-prophytic symptoms. The most common presenting feature is altered mental state, which is a non-specific marker of infection in older patients rather than with a younger person. You'd think it would be something neurological. With an older person, they might not get burning on passing urine and increased urinalysis or symptoms like that. Their symptom might be that they've got altered mental state and they've got newly diagnosed confusion. And I expect you've seen that, haven't you? I'm leaving a pause so anyone wants to share their stories. That's fine. You don't have to, though.
We often get people presenting with a delirium, which isn't necessarily sepsis because they might be vulnerable to and loss of function is often what we notice, isn't it? But then it's trying to do the detective work and
trying to rule out
and use our clinical assessment to work out, actually, I think this is tipping into sepsis.
Because again, if it was easy, people wouldn't be misdiagnosed every day, would they? You know, the other way older people can present is lethargy, tachypnea, which is increased respirations, loss of appetite, dehydration, weakness, dizziness, increased falls, and incontinence as well. So just to bear in mind, always be curious and suspicious and ask yourself, could this be sepsis? And we can often, the diagnosis and initiation of these sepsis bundles that we do, and we talk about the golden hour to have antibiotics. So, of course, antibiotics only work against bacteria. You're less likely to receive it when you're older as well, because you present in a more confusing manner. And that may be why they're overrepresented in deaths in sepsis. So, for example, as I said, older people may not get fever and chills. They may not get this classic symptoms of urinary frequency and pain. And they may, with pneumonia, instead of presenting with chest pain or bringing up foul sputum, they might just be weakness and falling more often. So that's why I think that your job is so difficult, because people do just present in really can appear difficult to diagnose. And just a bit of the stats. You know, if you've had sepsis, you're nearly 2 times more likely to have to be readmitted to hospital than if you were in hospital with a non-sepsis diagnosis. And more than 40% of older people have another hospitalisation within 3 months of their initial sepsis, most commonly because of a recurrence of the sepsis or infection. And we know that older people don't do that well in hospital. So what we want to try and do is avoid them going in. If you're in a nursing home, you're 6 times more likely to present in sepsis than if you're a non-nursing home older person. And there's a 3-fold increase in prevalence of moderate to severe cognitive impairment after hospitalisation, and a high prevalence of mental health problems such as depression and anxiety after sepsis, which is the other reason why we really want to try and avoid it, because it doesn't just have short-term consequences, it has long-term consequences as well. Has anyone got any questions? Happy-ish so far? Not sad? That's what I should say. These are sort of the most common sites of sepsis in the general population. And you can see with our population, it's going to be pressure sores as well. I bet you probably see them more often from respiratory and pressure sores, don't you, Amanda?
Yeah, and neurosepsis.
Oh, yeah. And these are sort of this is what you would see, how people can present, but also just doing a holistic assessment, not just the basic obs. What does the person feel like? What does she smell like? Do you know her? Is she behaving differently? Has she seem a bit more confused or drowsy than normal? You know, again, we're not going to be able to know what the blood results are straight away. So an elevated CRP is not going to help you in the community straight away, is it? Sorry, I've got fetal heart abnormality, but we're not very often looking after pregnant people, are we? You can do a capillary refill, but bear in mind that older people, like I said, if they've got warm hands, a capillary refill can be misleading. And if you've got darker skin, it can be hard to see if it's blanching or not. So traditionally, people used to do capillary refill because if you squeeze the tip of your finger or the centre of your chest for 5 seconds, it should unblanch in less than 3. So that's a sign of someone becoming shut down. So their blood supply has been taken back to their organs because they're unwell. But it's quite unreliable in older people, and it's unreliable with people with darker skins as well because you can't see it. So same if you can't, that mottled skin and rash you can get, it's a bit harder to see with people with black and brown skins. So if you're not sure, don't waste time trying to decide on something. Move on to the other things and look at the holistic picture of it. You know, look at the reduced urine output. What do we expect a normal urine output to be? Sort of at least 0.5 mils per kilogram per hour, isn't it? We used to say 30. Anyway, it doesn't matter what we used to say. I don't want to show my age, just in case. You know, look, a lactate is a very important thing. If you do following someone up in hospital nowadays, we really look at their lactate. Anything above 2 is or 4 is we're going to be in septic shock, because the inflammatory response means they need to use more oxygen in each one of their cells, so they can't be met. So then you do anaerobic respiration, and that's why you get the lactate. Do you remember your Krebs cycle from when you were in school? Thank you, Amanda. So that's why you get lactate. Lactic acid is a byproduct of anaerobic respiration, and that's why we look at it. Any questions? This is just for your interest. I know you're all fascinated. This is community screening. Can you see that? I don't know how big this looks to you. Is it big or small?
Okay.
This is a really easy tool, okay, which you could download from the Sepsis Trust. They've got ones for younger people, ones for older people, and ones for one in the community. But this is what has replaced the Sepsis 6, okay? So when we used to say, do you remember 5 in, 5 out? I mean, sorry, 3 in, 3 out. So this is just like, to start with one, does this person look unwell? And the risk factors for sepsis are if they're age 75 or over, if they've got impaired immunity like diabetes, or they're on steroids or chemo. And at this stage as well, you'd consider any advanced directive or care plans that me and Amanda are going to talk about. So if they've got any indwelling lines, they're more at risk of sepsis. If they've had any recent invasive procedures. And number 2 is if the answer is yes to that, is could this be due to an infection? Okay. And if sepsis is really unlikely, then you need to consider another diagnosis, not just ignore it. And number 3 is, are there any red flags present? So remember what we talked about? A new or altered mental state, respiratory rate above 25 is a red flag. If they need oxygen, we're aiming with older people to keep their saturations above 92 or 88% if they've got a predisposing respiratory condition. We want their systolic blood pressure to be 90 or above. Okay, so if it's below 90, that's a red flag. If their heart rate is above 130, if they haven't passed urine in the last 18 hours, or they've got a non-blanching rash, mottled, ashen or cyanotic skin, but remember, black and brown people, it's harder to see. If you've got someone with dark skin, look at places in their body that are lighter, like the inside of their arms or the palms of their hand, and look there. But if they've got any of these red flags present, you need to start the sepsis bundle. If there are any amber flags present, okay, they need to be seen the same day by GP or team leader, or I would say Amanda's team. So I'll just say, I don't know if you can see it clearly or not, so that's why I'm reading it out. So if the family are reporting any abnormal behaviour or mental state, if they've got reduced functional ability, if their respiratory rate is 21 to 24, or their systolic is 91 to 100, if the heart rate is 91 to 130, they've got a new dysrhythmia. If their SATs are less than 92 on air, if they haven't passed urine in the last 12 hours, if they're normally immunocompressed or they show any signs of infection, or if their temperature is below 36, okay, we need to have a management plan for those sort of clients. And I think that for both of these sets, with the red flags and the amber flags, Amanda, you'll be happy to give advice to your team, wouldn't you?
Yes.
But I think if they had red flags and they didn't have a directive against it, you'd be thinking about calling 999 and asking the ambulance service for advice, because time is really critical with these patients.
Yeah, so the key thing, if you were in the patient's home, you're the clinician who's concerned about sepsis is and your clinical assessment, your observations have all kind of added to that. It's more speedy for you to, and there's no respect form saying that they're not for hospital admission. Then it's faster for you to ring 999, and the bottom of the poster talks about that you really clearly say that this is a sepsis emergency, because then that will get you in them on a faster track for admission.
Yeah, good. And now they're using this sepsis. So they're saying people with sepsis present using the acronym sepsis. So like me, slurred speech or confusion, extreme shivering or muscle pain, passing no urine all day, severe breathlessness, I feel like I might die, so an impending sense of doom, or skin mottled, ashen, blue or very pale. And they're saying, although I think that our guidelines don't support it at the moment, if it's going to take more than an hour to get there and you've got a prescriber, then give IV antibiotics. But we're not doing that at the moment, are we, Amanda?
No, this is the dream, but we're not at that stage yet, and because we can't access the IV antibiotics, the drugs at the moment.
And has anyone got any questions about any of that? Or any times when you feel it might be ambiguous and you'd be concerned?
Is it possible for you to send this
Yeah, I'll send it out to everyone.
Thank you very much.
But I'll send these screening tools and the Sepsis 6 and the end of life screening. I'll send out separately, but they're downloadable from the Sepsis Trust. But I just put them on here for the presentation, but I'll send them separately where it's a bit clearer.
Well, thank you. Thank you.
Okay, of
What
course.
I kind of saw from that post though, also, it was the kind of amber. It's almost like it's really obvious when someone's not unwell, and we're great at saying, oh yeah, this person needs to be in hospital and it's appropriate to admit them. But it's the when you're dealing with ambiguity, and so this is where UCR, so depending on which area you're in, it's calling the SPA number and going through to UCR, speak to a clinician, and then that way it's seeing if there's capacity to get them assessed same day. And then that means they can be followed up on virtual ward. You know, if antibiotics are started, we think they don't need admitted, we can then follow them up on virtual ward and obviously send off bloods. There's point of care testing that we can do as well. And again, just to work out whether or not they can be cared for at home.
Thanks, Amanda. And there is I mean, the Sepsis Trust are internationally, their recommendations have been internationally adopted. So they are very, quite an authentic source of information. And they've got a different one for end of life screening. Okay, which can you see that?
Mm-hmm. Yeah.
So as you can see, it's like Marie Curie helped with this. And it's so the first thing you have to ask, we would be asking ourselves, is this a new and potentially reversible illness? Because if it's an ongoing part of their original illness where they were put on their end of life care, I think that we would be less aggressively treating it than if it was a new and possibly reversible illness. So if the answer to that is yes, do you think your patient might have an infection? And you can see again the likely sources like chest, meningitis, urine, and you consider this or whether this patient is just actively dying at this time. So I think that it's very difficult for you when you're looking after patients like this. And would an acute hospital assessment be appropriate for this patient? Have they got an advanced care plan, a respect care plan? And I think this is where you might consider again calling Amanda's team for advice about it, because you might want an urgent assessment in the community so that rather than transferring them in. And again, you'd have to look at, are there one or more of the red flags that we were talking about?
And so, yeah, Jane and I were talking about it earlier. Obviously, some people's respect forms, you know, they're happy to be admitted for reversible causes, ward level care. So even if they weren't for resuscitation, it's still appropriate to admit to hospital so that they can get those IV antibiotics or IV antifungals, IV fluids. But for some of our patients, and probably you're aware that actually they are end of life, to admit them, particularly if their respect form says not for hospital admission, that it's comfort is their priority rather than saving life, that it's to treat symptoms at home or their preferred place of residence if it's a care home, then actually, you know, we want to avoid them dying on a hospital trolley. And it could be a lot of our the trajectory for our patients who are end of life. It could be that they've had Parkinson's or dementia, that actually aspiration pneumonia is going to be you know, what they end their days with. And it could be that antibiotics at home can buy them a bit more time, can, you know, get in that bridging care and support families with that, and also support symptoms. But sometimes actually it is, you know, an infection like a catheter-acquired UTI or a urosepsis or a respiratory, again, chest infection, pneumonia, that actually this is part of their end, and it is about symptom control, treatment at home, all the support that we and our teams are good at giving, anticipatory medication. And so yes, it is involving, you know, again, an urgent response, a UCR response, if that would support you and you're the person who's identified, actually, I think this person might be tipping into dying now rather than just the end of life phase.
Has anyone got any questions about that? You I think you're probably more experienced than me at making these sort of decisions when you're with people. But there's always people you can ring up and ask for advice. And that's the other thing. We're never totally on our own. And this is just a screening for an acute assessment if you needed it, okay? So just to show you the difference. So I won't go into it again, but just about for non-older people, not in a non-community setting, really, just for your interest. And in that one, just if you're thinking about your own communities, for children, again, there's slightly different things for children and pregnant people. And this is a new Sepsis 6, sort of. So the most important thing now is that if you suspect sepsis, they should be seen by a senior doctor. That is number one, okay? And they should be seen with them as soon as possible, and it should be a junior consultant, really. So the most senior clinician you've got available should be seeing this person, because some of the reasons why sepsis was not diagnosed is because just very junior staff were looking after them, and it's difficult to diagnose sometimes, and it can present in different ways. Okay, give oxygen if required, but you don't give it routinely now. You titrate to keep their saturations above that level I spoke about, so above 92 or 88% if they've got a pre-existing chronic obstructive airways disease. We're going to send bloods, including cultures, okay, and we're going to give IV antibiotics, and if they're pregnant, we would help to extrapolate the baby. We're going to give IV fluids, but again, with older people, we're going to titrate it against their blood pressure, because what we don't want to do is end up giving them pulmonary edema either. So we want to try and keep their systolic above 90 if we can, okay? And we're going to monitor them. And this is the new Sepsis 6. If people talk to you about the Sepsis 6, that you should, when you do your ILS and stuff, this is what they should be talking to you about. Any questions about that?
I think most of this would be delivered in hospital.
Yeah, I would. You're right.
This is all. We can't start oxygen or send off blood cultures, so it's, yeah, in a way, us starting a sepsis bundle is calling 999 with a sepsis, spelling out to the you're not necessarily talking, when you call 999, you're not necessarily talking to an experienced clinician. These are call handlers, and you're the clinician, and so you have to make it really clear that it's a sepsis call. And then that way, in a way, the bundle is starting, because you're getting the person to the acute care where they can get all of this attention.
So true. And just again, really early recognition, antibiotic treatment and fluid resuscitation. Delivering this within the first hour is the most effective life-saving treatment we can give. And that's why it's so important that you have a high index of suspicion for sepsis and you escalate it, like Amanda said. Even an hour's delay can increase mortality in our patients because of their frailty already. And if they do survive it, their cognitive impairment afterwards is likely to be worse. Okay, it should include strategies to control the source of infection as well. And always think about the impact. So when it's fair enough, you won't be doing this so much, but what we should be doing is doing the treatment, stopping to assess how it's worked, and then moving on to the next thing. And remove the source. So if you know the source is an infected cannula or an infected catheter, we should be removing it. And that's just, again, if you like it, the Sepsis 6. Just because not everyone likes posters. Okay. So just to go through it, but seemingly, do you think I shouldn't be going through it? It's just some of you might work in the acute side, and when you do ILS, if you work in a bedded unit, this will help you. So it's really about experience. Okay. We need to give high flow oxygen. Remember that us nurses and healthcare professionals can only give 100% oxygen without a prescription. So if you're giving oxygen without a prescription, it has to be 100%, 15 litres. It can't be anything else. If you're titrating it with the oxygen saturations, it needs to be prescribed. Because remember, in sepsis, a critical imbalance exists between the oxygen demand of the tissues and its supply, and that's what causes the build-up of lactate, and that's what causes some of the damage. Okay, these are the bloods we'd be looking at, and blood cultures as well. We should try and take the blood cultures before we give antibiotics. Often we're going to use, like, obviously, if they're not allergic to penicillin, coamoxiclav, amoxicillin, cefuroxime, cefotoxins, and if we can remove the source, this is when we plan to do it as well. You can see each hour delay increases mortality by 7.6%. Consider IV fluids. Again, we're not going to give it routinely the way we did anymore, because what we have done in the past is overload people. And this is what we're looking at. We want really the urine output to be 0.5 mils per kilogram per hour. And we want to do a Muse chart as well. So sorry, I've got Meow's chart from maternity. But we want to do a patient at risk chart. And you've got them on your EMIS, haven't you? And they're on EMIS and Amanda. So they will automatically flag up what the observations are and what their score is. But that's a useful way when you're handing people over as well.
Meows.
Yeah.
Has anyone got any question?
When EMIS will give you a sepsis.
Most patients, well, 64% of patients that get sepsis will get AKI, so an acute kidney injury as well, as part of their pathophysiology. So that's why if they're in hospital, we would expect them to monitor the U's and E's as well. We need accurate urine measurements. So if you're with someone in the community waiting for help and they go to the toilet, we need to measure it, because it's going to be an important part of the pattern of deciding how unwell or well they are.
We have news too.
And that is all my references. The other thing I would just say is, sorry, I cut some of the acute stuff out because, as you said, Amanda, it's not really relevant to the community. The other thing that is, if people will often leave ITU and HCU with some quite high degree of trauma connected to it. So younger people are more likely to be offered psychological support than older people. But I think that we need to make sure that our clients as well can access the care they need to recover from this very frightening thing that's happened to them, where they often feel very out of control, and they really feel how life-threatening it was, and it takes time to get over that. Has anyone got any questions about any of that?
No.
I was just going to say.
Go on, Amanda.
Oh, so sorry. We use News 2 Score in the community. Usually it's kind of worth having a laminated chart for your teams, because EMIS Mobile doesn't kind of give us a warning. We have to be working out our own News 2 Score. And whereas when you get back to the ranch and update your notes, then you'll get a sepsis warning, and it's deciding. So we have to kind of almost be working out our News 2 Score with the patient while we're with them, working out why we're concerned, how many parameters they're showing, whether they've got a low temperature, or they're tachypneic or tachycardic, low blood pressure. So and then of course their oxygen sats as well. So it's equipping our teams to think about News 2 and having escalation, because actually it's not registered staff, it's our unregistered staff who are going to do the insulin visit, and they just think this person isn't they're not functioning, or cognitively they're not as good as usual, and so it's equipping our unregistered staff to be able to escalate.
That's interesting. So have a high index of suspicion for sepsis, and if you're not sure, ring someone up and ask and check. That would be your take-home message. Would you agree, Amanda?
Yeah.
Yeah, it's better to ask someone than ignore it.
Yeah.
I will send this out to you along with the things from the Sepsis Trust. But has anyone got any questions or anything they want to share, or a patient they saw that they weren't sure what to do and they would like to talk it through with us?
No.
Is it being useful or not as useful as a chocolate teapot?
No, it has been useful. Thank you.
Very useful. Thank you.
Perhaps not very useful, but slightly. It's always useful to revisit sepsis, I think, and it's again. So I do think that we've always got these things up saying, we always think of sepsis and it's on the lift and stuff, but it can have a very subtle presentation to start off with. Okay, well, I will let you all go on the Tuesday afternoon.
Thank you.
And thank you so much, Amanda, for hopping in at the last minute and helping me out.
Our pleasure, Joy. It was a great update for me. Thank you.
Thank you.
Thank you. Bye.
And yeah,
Okay.
if anyone wants to
Bye.
deliver any bite-sized learning, we're starting a new program in January. Or